All right. So I think it's 2:30 and we have quite a few people on already. So we will go ahead and get started. Today's presentation is on long-term healthcare post-transplant. And we have one of our PAs from here at the center, Barbara Fishkin, who's going to speak to you guys today about this topic. Just a reminder, you're all going to stay muted until she's finished speaking, and then once she's done speaking, I will let everybody unmute themselves so you can ask any questions that you have at that point. So if you want to just jot down any questions you have while she's talking, that would be a good idea. But otherwise, we will go ahead and get started.
Well, hello, everybody. Again, my name is Barbara Fishkin. I'm a physician assistant. I've been with the program for about 10 years. I've seen people go through the transplant and now the long-term complications after transplant. I don't want you to get nervous about the complications from transplant, because the most important thing to realize is that that we are all aware of these complications, and you will see that post-transplant you're followed very closely. So we prevent, if we see any complications occurring or anything changes, we will hope to prevent any of these complications. If that makes sense to you? Okay, so we can move along. So we have a lot of liver transplants, and this is why we're aware of, we see a lot of people going through transplants. Go ahead. And the survival rate of a transplant is very good. It's for 1 year, it's over 90%, 3 years and 5 years. So people do really well going through the transplant. It's a big surgery, but it's really people miraculously, after transplant, you'll usually meet with the PA or nurse practitioner and the doctors, within the first, after you're discharged. And most people say they can't believe how easy a surgery it is. Okay. The long-term complications that we're going to go through are the metabolic syndrome, which includes, which I'll explain, high blood pressure, obesity, high cholesterol, diabetes, kidney disease, bone disease, any kind of brain issues, sexual dysfunction, cancers, and infections, which basically says there's something of everything in a bit. That includes, as people age, they are going to run into these complications in general. So you're going to find it, because once you've hit, even like people going in with cancer, once you're hit the 5-year mark, your complications are what everyone's complications are by just aging. Metabolic syndrome. So metabolic syndrome, or any 3 of these of the following 5 traits, which is abdominal obesity, your triglycerides are elevated, you have a low HDL cholesterol, you have high blood pressure, and you have fasting glucoses that are elevated. Now, this is something that is pretty much, it has nothing to do with really transplant. It has to do with the fact that a lot of people in our population in the United States have these things, and more people are becoming heavier, and they have a waist circumference that's bigger, and high cholesterol, high blood pressure, and diabetes. So some of the medications that you'll take post-transplant might relate to this, and we have to monitor for this. Especially people a lot of times feel so good after transplant, they start eating so much and they start gaining weight and getting into these problems. metabolic syndrome, which a few of these slides kind of repeat themselves, but the prevalence of this could be over 50, up to 50% 1 year after liver transplant. And again, like I said, some of the medications like prednisone is a medication that there are 3 immunosuppressions we start people on, one of them being prednisone, which gets tapered off by 6 months. And that medication could affect the metabolic syndrome, um, initially, like some people get diabetes because they're induced from the prednisone, which can go away once they're off the prednisone. But again, a lot of it from what I see is people just eat a lot. And, people being home now with COVID, sitting in the house, eating a lot. Like we joke that there's a COVID diet, which is 20 pounds extra. Metabolic syndrome risk factors. Okay, so pre-transplant, people are are at a higher age of transplant. If they have any borderline diabetes before transplant, if they're smoking, fatty liver disease, hep C infection, all that can affect the metabolic syndrome. And post-transplant weight gain, again, I said use of steroids and immunosuppression medications. Why does this matter? Because like anything, the number one cause of death in the United States is heart disease, is so cardiovascular events. So again, we don't want our patients to go through this wonderful get a second chance at life with a liver transplant and then have cardiac issues. So we watch and make sure that they don't, um, you know, get into issues with cardiac disease. Okay. So hypertension is part of that as well. And some medications, one of the immunosuppression medication, which is called tacrolimus, which is not everyone will be on this medication, but that's our number one medication to go through. Sometimes it can affect blood pressure just minorly, and it can increase your blood pressure. So we monitor that, and sometimes people need a blood pressure medication initially when the the tacrolimus is on the higher side, because again we taper it off and we give them blood pressure medications. And if someone has a high develops diabetes, or in the beginning has a high glucose, will get endocrine involved. Sometimes people, before they become a transplant, before they go through transplant, they're already diabetic. They might have their own endocrinologist, or sometimes their primary care doctor manages their diabetes. So we get everyone involved. We also often check your cholesterol lipid panel, although that's something that the primary care doctor will make sure that you might be checking you with them. And we hope that everyone exercises and feels good. And again, it's like anything else. We don't want you sitting home, eating, not exercising. Your liver is perfect, but then you're starting to have heart disease. Blood pressure. I think I said that, the medication induced aspect of blood pressure. How can we treat hypertension? Okay, so this is primary care follow-up is in bold, and I'll get back to that. Salt restriction, remove excess fluid, minimize the anti-rejection medications. We taper the steroids by 6 months, and we give medications initially. Well, going back to that for a second, is that the reason why it was in bold is that it depends on the person, and everyone is different. Some people love going to their primary care doctor and have a really good relationship with them. Some people never go to their primary care doctor. So after transplants, when you might be talking to me at least weekly, if not a few times you know, a few times a week, and then initially you see me once a week, or if there's any complications, twice a week, and then every other week. And you get to know us very well, and then they forget that their primary care doctor, they'll say, oh, you're my primary care doctor. And it's all the time. So the primary care follow-up, your primary care doctor who's been treating your hypertension, or other issues prior, we like you to follow up with them and make sure that they are also seeing you as well. So that's essential. Obesity, weight gain is frequent, I said before. A lot of them is, like I said, you feel so good that you don't stop eating. Um, Decreased physical activity and steroids. Sometimes in the beginning, people are afraid to exercise, but we encourage exercise. It's hard right now with COVID because people don't go to the gyms as much and things like that, but just getting up and walking around, even that can be difficult during these times. But some people are on the steroids a little longer than others. Um, but again, to treat it, we want to make sure you eat well. We have a dietitian who can help with diet, and it's like anything else. Weight is not an easy thing to handle, but with your care partner there, you'll be doing a good job, I'm sure. High cholesterol, again, it's really the same thing I said before with the steroid use and anti-rejection medications. Certain um, anti-rejection medications we don't use if someone has a high cholesterol. So what um, what we do is we change things around. So if someone has a high cholesterol, we might take you off one um, anti-rejection medication and put you on another. And statins are able to be used. Certain ones are preferable than others. So you're always looked at in a total picture. So again, wouldn't start a person on a statin that might have that might be associated with a higher cholesterol with someone who's already got a high cholesterol. We just pass that over. So the idea is we are aware of all these complications that people can have, and we're there to help and prevent it from happening. Pre-liver transplant diabetes is present in 10 to 15% of our recipients, and a lot of them are already insulin dependent. Then, so, and then there's 4 to 30%, there's a big range of patients who develop diabetes due to metabolic syndrome and some of the medications. Sometimes, again, there are three anti-rejection medications, one being prednisone, and that gets tapered. And as that gets tapered, if you had an issue with diabetes, um, we hope that it goes away. If you are diabetic already, then your sugar levels, your glucose levels will be increased when you're on the prednisone. So we work with the endocrinologist ahead of time to increase your medication so your levels are okay. And again, that's what I just said. We work with the endocrine team to work that out. The other issue is kidney disease. So again, some of the medications being Prograf can increase your kidney, can decrease your kidney function or increase the risk of having a kidney problem. And that could be, so what we do is we measure your blood work all the time. And if your kidney function, which is often we look at the creatinine, if the creatinine starts going up, we'll say, hey, what's happening here? Maybe we have to adjust your immunosuppression. And if it goes up too much, we might have to change their immunosuppression. So again, a lot of it has to do with your anti-rejection medications. If you're a diabetic before transplant, your kidney function might not be perfect to begin with. And if you have high blood pressure, your kidney, this is before transplant, your kidney function might not be perfect to begin with. So the thing that we have to do is we look at you, we know what your problems are, which medications we can work with and not work. A lot of our patients actually before transplant, a lot of liver people have the opposite, low blood pressure. But it's something we watch closely and change if there's any kidney issues. We can skip that one. Poor bone health. Again, one of the things we check before transplant in part of your eval is if you have we check your bone density. So sometimes your bone density isn't great because of any kind of, we check your vitamin D status. A lot of people have low vitamin D because vitamin D is made in the liver. A lot of people have weakly vitamin D. So we check your bone status before. Sometimes medications affect the bone turnover. So every 2 years, we do a bone density for all our patients to make sure and check, and you're on calcium to make sure we keep your bone health good. Post-transplant causes. Again, like what I said before, we check steroids, and sometimes people with cholestatic liver disease, PBC and PSC, have more bone issues, and you'll see a rheumatologist or a endocrinologist, and they can help you with if you need any medications to cause, so we don't cause osteoporosis. Again, that's what I just said. Neurological, sometimes you can get tremors or headaches. Sometimes before transplant in eval, we check to make sure you're not tremulous after transplant too, because that could also affect the medication can affect if neurological, if you have tremors or headaches, tingling, numbness. So again, if you have any of these things, we have you do your blood work and make sure your Prograf level is not too high. Sexual dysfunction, again, women will have their menstrual cycles return, so pregnancy can happen. Sometimes people have difficulty with erections because of the diabetes, loss of libido. So that's a lot of times before transplant and after transplant. So that can be, discussed with your primary care doctor. Cancer, we don't have to go through all these things, but because you're on immunosuppression, we have you, I'm sorry, because you're on immunosuppression, any kind of, which we'll get to, you're at risk for more infections and you're at risk for more cancer, in the sense that your immunosuppressions, lower your ability to fight infection because you're on these medications. So your body is not rejecting the liver. So we try over time. That's why your immunosuppression is lowered. You're at the highest amount right after transplant, and we try to get you off of two of the medications, and you're only on one immunosuppression unless you have an autoimmune issue that caused the need for a transplant, and then you're on two. But we try to lower it as much as possible because we don't want the risk of cancer infections coming in. So, we tell you to make sure you have, use, most of it is skin cancer, and we make sure, you wear hats, and, you wear sunscreen, and you go to the dermatologist and check to make sure you don't have any kind of skin cancer. If you had cancer prior to transplant, if that is one of the issues that you've had, we do scans regularly after transplant to make sure this doesn't, it hasn't reoccurred. Again, non-melanoma skin cancer is the most, you can go back, is the most common basal cell or squamous cell. And you just, again, a lot of people do not like to go to the dermatologist. I don't know why. I mean, so, we usually, just have to recommend that everyone does their regular screening that they're supposed to do. Everyone's supposed to go to the dermatologist once a year, go to the GYN, go to the urologist for a man, do all their regular screenings that they're supposed to do. And we just encourage that they continue to do that. So the colonoscopy every 3 years, it all depends on everyone's risk. You get your prostate checked, the GYN, breast exam, esophageal, EGD. That's only if you have something called Barrett's esophagus prior. These are just normal screenings that the whole population should go for. Infections can occur. Different types of infections can occur. The main infections are bacterial, viral, and fungal. Post-transplant, you'll be put on antibacterial, antiviral, and antifungal medications. And by a year, bacterial infections, after a year, you're on a prophylactic medication for a year. Viral infections, you're on medications for 3 months, because most of the viral medications will occur within 3 months. One of them, the most common one, being something called CMV, cytomegalovirus. In your transplant eval, we've tested to see if you've been exposed to this virus. Most people have, they just wouldn't know it. But a lot of times that virus can happen within the first 3 to 6 months of transplant, mostly in the first 3 months. So we preemptively put you on medications so you don't get this. But we check it within your blood work all the time. And if you do develop that, and we would pick it up so fast that you wouldn't even, most people don't even have any side effects from it, which is really, diarrhea, increased bowel movements. We would see it, pick it up in the blood work and put you back on the medication. The fungal infections, usually we put people on fungal prophylactic when you're on the prednisone, which is like a nice statin, just to prevent any kind of infection. So we are aware that these things happen. So we try to avoid it from happening by putting your medication on before it even happens, and then treat it if it happens. Oh, see, here we go. CMV, it always pops up. That's the one I just said. So if your donor had CMV and you didn't, you might be more at risk for it. So we check in all your labs before, and we know how to adjust the medication specifically. Sometimes when if you do have, I don't want to, this might be a little too much to know, but if you do develop an infection, what we do is lower your immunosuppression, and it has to be a balance that we do because we want to make sure you don't reject your liver, but you also have to be able to treat the infection. So we make adjustments in your medication, and we at least 2 weeks of high dose antiviral. That's what we do. We lower the antiviral. Teaching points: overall survival improved with liver transplant. Long-term mortality from liver transplant. Some people who have autoimmune causes of transplant, they can reoccur years down the line. So that is a problem. Sometimes people even get another transplant. Complications from drugs, if we have drug complications, like the kidney disease, the CMV, if someone has any, gets headaches, we have to take that into account. We again manage the metabolic syndrome, and we ask that your primary care, endocrinologist, cardiologist, they all work together post-transplant if that is something that comes up. There is a higher risk of cancer, so we have to screen for that. A higher risk of infection and should seek medical attention without delays. What that is saying is that's very important because everyone is different, and some people, like, I don't know what everyone's experience has been with transplant. When you call us, we get back to you within the day, and if anyone has any issues with any concerns, they should call. And sometimes people are afraid to call, or sometimes people are afraid to call because we might say, you have to go to the hospital, and they don't want to go to the hospital. If they're running 102 fever, I'm saying, they don't call. They want to see how the next day goes, that kind of thing. And that other slide just meant that the sooner you call us and we find out what the cause of a problem is, then it doesn't escalate, if that makes sense. So all these things are anything, in a sense, it's anything that anyone could actually get, could get involved with like blood pressure, hypertension, cardiac infections. All these things can happen, but we're aware of it and we try to prevent them from happening, if that